My essay is on the link between violence and mental illness, and whether mental illness is a cause of violence in itself, or whether it's merely associated with it. My interest in this question began when I was doing a research fellowship at the IOPPN. I was helping to evaluate a pilot study aimed at ending the cycle of domestic violence in families, and there were high levels of anxiety and depression amongst the perpetrators. Treating these mental illnesses was a key strategy in preventing the violence. So the essay competition gave me the impetus to explore this link in the literature, because as I'd now seen, violence has a devastating effect not only on the victim, but also on the perpetrator, the families involved, and society as a whole, not to mention the financial costs. If mental illness does lead to violence, then we as clinicians can do something about this by improving our risk assessments and management of patients, and hopefully preventing violence from cycling through generations. I realise now that I chose a subject that was quite big for one essay, and this prevented me from going into great detail. What I wrote about were broad areas of contention, and to anyone listening, I'd be very interested to know your opinion on these. At the heart of this question lies substance use. It's clearly very difficult to disentangle the main cause of violence when substance use and mental illness overlap, which happens frequently. This is often because of the way violence is reported. For example, in domestic homicide reviews, there may not be detail on exactly what type of substance was being used and whether the perpetrator was intoxicated or experiencing symptoms of mental illness at the time of violence. There's a convincing body of evidence that the likelihood of mental illness causing violence is small when controlling for substance use, although it seems that some would argue that mental illness could still be the causative factor. Could it be that patients with co-occurring substance use might be more likely to be non-concordant with treatment and thus more symptomatic at the time of the incident? Another point I considered was whether common mental illness was linked to violence in the same way as serious mental illness, such as schizophrenia. This seems to be the case amongst perpetrators of domestic violence, where screening for depression has been used to identify potential perpetrators in emergency and primary care settings in some countries. As common mental illnesses are far more widespread, do they make a greater contribution to violence than serious mental illness? Finally, I considered how effective medications are at reducing the risk of violence, and whether the symptoms and age of a patient affect their risk profile. Overall, I learned that a wider response to violence is needed because there are so many pathways to it. Medications like antipsychotics can make a difference, but the biopsychosocial approach is essential given that so many patients don't respond to this. This essay has sparked many questions for me, having started with an interest in common mental illnesses and domestic violence, and ending up leading me towards thinking about serious mental illness and substance use. These are all questions that I hope to explore further. Thank you for listening.
I wrote an essay on whether the generally prohibitive stance of the UK inpatient forensic system on sex and relationships is a justifiable exception to Article 8 of the European Convention on Human Rights, the right to respect to his private and family life. I'd be really interested to hear your views around current and future practice in the area. A major concern around permitting sex is the risk of abuse or exploitation in a population which may contain particularly risky and/or vulnerable people. However, could individual risk assessments mitigate this? Moreover, it seems to be the case that sex does still happen despite prohibitive policies. Could banning sex mean that those in exploitative situations are less likely to speak to staff about them? Relationship breakdowns may cause distress or mental health relapses, and allowing sex in relationships could cause jealousy and hostility on a ward. However, these emotions can never be fully excluded from an environment. Moreover, if the ultimate aim of a forensic stay is reintegration into the community, where these situations will inevitably be encountered, then perhaps such issues are actually best addressed when patients have the high level of support available to them whilst resident on a unit. Even if a relationship will ultimately end badly, unless there are significant safeguarding concerns, doesn't the right of a capacitous patient to make potentially unwise decisions win out? What about the potential positive impacts of relationships on mental health, progression, and likelihood of a sustainable living arrangement on release from the unit? And could barring sex in itself cause the breakdown of relationships, both between inpatients and with partners outside the unit? Prohibiting sex has been argued to reduce the risk of STIs and pregnancies on wards. But if sex is still happening under prohibitive policies, could its prohibition in fact increase the incidence of these via less access to and use of contraception? Could sex being depicted to patients as only ever a bad thing over a long-term stay lead to its understanding as an inherently predatory action and therefore usage in this way in the future? Of course, there may be many practical barriers to enabling sex on a ward. Would staff be to blame for any negative outcomes? How could a safe, private space be enabled, and what could realistically be asked of staff to enable it? If risk assessments were proposed for each relationship, would the administrative burden be insurmountable? How would you begin to factor in all of the variables affecting risk or vulnerability in every relationship? On the other hand, could similar points not be made of existing risk assessments for ward activities involving sharp objects, unsupervised alone time, or leave? If the alternative is a blanket ban on a human right, should it not at least be given some more consideration? Perhaps national guidance for individual risk assessments for sex and intimacy could pave the way for a forensic system which evaluates sex in relationships as it does any other valued freedom of its input.
Good afternoon, everyone. My name's Beth, and I'm going to spend a few minutes today talking about my essay, Ethical Considerations and Political Abuse of Forensic Psychiatry. I wrote this essay because I wanted to explore, from an international perspective, the power that a psychiatrist, and in particular a forensic psychiatrist, has over their patients at an ethical level, and look at where that power comes from and what can happen if that power is misused. And of course, the ultimate power of the psychiatrist is derived through mental health legislation at a state level. And through its governance in law, the final decisions about forensic patients lie not with doctors, but with politicians and the electorate. And this leaves it open for manipulation, both by the state and by public opinion. And I think as medical explanations for supposedly deviant behaviour have become predominant in understanding these patients who pose an ongoing risk to society, so has responsibility increasingly fallen to forensic psychiatrists to detain and manage such individuals. And this can be seen with the UK government's solution of preventive detention for dangerous severe personality disorder, or when the US Supreme Court stated in 1997 that states have a right to use psychiatric hospitals to confine certain sex offenders once they've completed their prison terms, even if those offenders do not meet mental illness commitment criteria. And I think the lack of clear-cut boundaries for what constitutes a mental illness, and therefore the foundation of our mental health acts and powers, means there's the potential for well-meaning psychiatrists to perpetrate political abuse using their understanding of mental illness within oppressive societies. And perhaps the most famous example of this is the advent of sluggish schizophrenia, coined in the Soviet Union. And although this was likely created by the government, it was thought to have been accepted by most psychiatrists at the time, as it explained the seemingly illogical behaviour of political dissidents in a perceived utopia. But of course, the political abuse of psychiatry started with its very conception. From asylums that were used to relocate prostitutes and orphans, through to drapetomania, which explained why escaped slaves would abandon the supposed civilizing effects of Western culture, or more modern times with the interrogation of terrorists in Guantanamo Bay, or in the restriction of LGBTQ rights, where, for example, in Russia, transgender was added to a mental illness list which could prevent a person from driving. And I think the same story has been told time and time again. The medicalisation of deviancy has been used throughout the ages by the ruling classes to perpetrate injustices. And it is only by continuing to be aware of the potential for such manipulation and developing an evidence base to contradict such attempts that we can reduce the scope for such abuse. Thank you so much.